between 2001 and 2010, the richest had a 68% healthcare coverage, while the poorest had a 49% coverage. 1 decade later, 2011 to 2020, this is nearly halved for the poorest, where the richest moved from 68% to 73%, but the poorest showed an even more drastic increase in coverage from 49% to 62%, thereby closing the gap. So we have made some strides, but we're not quite there yet. Something to consider: eliminating wealth-related inequality in under 5 mortality could help save the lives of 1.8 million children in low and middle income countries. Then the WHO Commission on Social Determinants of Health was initially established to support countries and global health partners to address social factors leading to poor health and inequities. Now, they have developed this structural framework which demonstrates how social, economic, and political factors such as income, education, occupation, all influence a person's socioeconomic position, which in turn plays a role on determining their health outcomes. And something that was very simply put by the Director General, Dr. Margaret Chan, she mentioned that healthcare is an important determinant of health. We know this. Lifestyles are important determinants of health, but if it is the factors in the social environment that determine access to health services and influence lifestyle choices in the first place. So until we were able to address these social and environmental factors, we will not be able to achieve global health equity. The World Economic Forum has a vision for health and healthcare in 2035 with the ultimate goal of equity. And it is through 4 main strategic pillars that they are suggesting. 1 being equitable access and outcomes, where we are ensuring equal representation and access and outcomes for all. We have to have healthcare systems transformation, where we are structuring resilient healthcare systems to provide high quality care. We also have to put significant emphasis on technology and innovation, where we are cultivating an environment to support innovation in science and medicine, as well as environmental sustainability. We have to speak more about this. We have to reduce the impact on the environment, and we have to prepare for and address climate change. How can we do all of this? Well, it starts with strengthening the healthcare system. We have to address the determinants of health, being the social, the political, and the environmental factors. We have to promote healthcare coverage. We have to combat infectious and non-infectious diseases and improve maternal and child health, address mental health, foster collaborations and partnerships, advocate for global health equity, and it doesn't stop there. We have to then monitor and evaluate our progress, and the cycle starts once again. Now, what will it look like? For the WHO, it will look like 1 billion more people benefiting from universal health coverage, 1 billion more people being protected from health emergencies, and 1 billion more people having better access to better health and wellness. And for the CDC, that means we create availability. We have sufficient quantity of functioning public health facilities. We have accessibility without discrimination, and it is physically accessible and affordable for all, as well as acceptability. We have to ensure that it is respectful of medical ethics and culturally appropriate, as well as sensitive to gender issues. And the quality, we have to ensure that it is scientific and medically appropriate, good quality public health services. We have to further prioritize the needs of the most disadvantaged or disproportionately affected. We have to collaborate with external partners and implement good, ethical public health practice. Engage in the affected population and communities to better understand their need and confirm that programs uphold principles of human rights and cultivate ethical and knowledgeable staff. Now, what role do we play as surgeons? We have to work towards achieving global surgical health equity. And it is the Lancet Commission on Global Surgery had their initial landmark report of Global Surgery 2030 with the vision of universal access to safe, affordable surgical and anesthesia care when needed. It was an astounding 28 to 32% of the global burden of disease can be attributed to surgically treatable conditions. So this is substantial, and it continues to grow. And despite these statistics, there continues to be gross disparities in access to safe surgical and anesthesia care worldwide. We can see here a geographic demonstration showing the proportion of the population without access to safe, affordable surgery and anesthesia by region. We do know that surgical and anesthesia care is a neglected component of health systems, particularly in low and middle income countries, as we can see here. And this has resulted in lack of access to safe and affordable surgical care for 5 billion people worldwide. And we can see here it affects mainly countries within the regions of Western, Eastern, and Central Sub-Saharan Africa, as well as South and Southeast Asia. Now, it's important that we make it known that surgical care is an indivisible and indispensable part of healthcare. It is necessary to achieve local and global health goals, including the Sustainable Development Goals and targets for universal health coverage. Policymakers, implementers, and funders must include surgical care as a necessary part of national health and developmental strategies in order for us to provide high-quality care. Now, the Commission on Global Surgery also estimated the annual unmet surgical need by region. And again, the regions that we see most often affected include the poorest regions of the world, the Western, Eastern, and Central Sub-Saharan Africa, again, as well as South and Southeast Asia. An estimated 143 million additional surgical procedures are needed each year to save lives and prevent disability. Now, the need for the surgical care is greatest in these regions. So, to achieve the universal access to surgical care, the Lancet Commission on Global Surgery has set a target of 80% coverage of essential surgical and anesthesia services per country by 2030. And this will require integration of surgical services across levels of care and commitment to addressing factors that cause delays in seeking, reaching, and receiving surgical care. Again, when we speak about achieving global health equity and surgical equity, we have to consider the economic impact. So we know that investment in surgical and anesthesia services is not only affordable, but also it saves lives and promotes economic growth. Here we can see in this figure, it demonstrates the annual and cumulative GDP loss in low-income and middle-income countries from 5 categorical surgical conditions. But we have to scale up surgical services to meet the current population needs, and this would require significant financial investment, but the cost of inaction on national incomes would be far greater. The lost output and total GDP losses from untreated surgical conditions would cost low-income and middle-income countries a total of $12.3 trillion. And we have to make sure that there's protection against catastrophic out-of-pocket payments. Currently, 33 million individuals face catastrophic health expenditure every year, and this is due to paying for surgery and anesthesia. So, in addition to this, 48 million cases occur when non-medical costs are included. So the Lancet Commission has this aim to achieve 100% coverage and protection against catastrophic expenditure from out-of-pocket payments for surgical and anesthesia care by 2030, with the ultimate goal of creating global surgical equity. So in conclusion, global health equity is achievable, but through collaboration, investment, and strategies to eliminate disparities. Equitable surgical care is an essential component of achieving global health equity. Successful equitable change must be locally driven and globally supported. Thank you.
Thank you, Dr. Corbin. We're kind of a little over time, so I'm going to keep us on, and we'll hold questions to the end if we have time. Thank you so much. Next we have Dr. Katayoun Madani from Paradise Valley, Arizona. She's an MD Anderson Fellow in Global Surgery Policy and Advocacy at the Baylor College of Medicine. Speaking on surgeons shaping global surgery policy. Dr. Madani.
much for the opportunity to present. I don't have any relevant disclosures. Yesterday, we heard a very inspiring talk by Dr. Newman regarding global surgery policy and advocacy. And today, I hope to share with you some of the work that surgeons have done so far in the arena of impacting policy across the globe, locally and nationally. I hope to tell you about the importance of ICS as an organization in this regard and the current and future policy changes that are necessary, and call to attention the critical importance of empowering surgeons' voices in policy and advocacy. Before anything, though, I want to take us back to the definition of global surgery. We have a meeting today, and we are talking about global surgery in many, many different ways. If I ask across the room, there will be many definitions of what global surgery is, because this is really a matter of perspective. Some are going to tell me it is a rural surgery, some think it's surgical admissions, some think it's capacity building, and to some of our colleagues across the world, it's actually just surgery because they practice in resource settings every day. There are definitions such as the definition of academic global surgery that has been cited in literature. But what is very important is at the core of all these definitions, we all have one thing in common: the neglected surgical patient. That is what's at the core of all these definitions. It's quite special to be here and talk to you about policy and advocacy in global surgery, as the first landmark moment in global surgery advocacy was actually the address that former director of WHO, Dr. Wertheim, delivered at the 22nd World Congress of Surgery in Mexico City, which was an ICS meeting in 1980. During that meeting and that historic address, Dr. Muller called the disparities in access to surgical care the most serious manifestation of social inequity in all of healthcare. So you may ask, then what happened? This was 1980, and here we are in 2024 and talking about so many disparities remaining. Well, here I have a timeline for you of advocacy and policy. This is some of the highlights. By no means it needs to be comprehensive of everything that has happened, but as you can appreciate, between 1980 and 2005, there is a gap. After that address, HIV epidemic began. And so the entire global health perspective shifted towards infectious diseases. It was HIV, then TB, then malaria, and so on. The investments all shifted towards taking care of infectious diseases. And between 1980 and 2005, I'm sure there are many people across this room who can tell me what was happening in global surgery because you were delivering global surgery through your missions and capacity building efforts across the world. Now in 2005, we saw the Global Initiative for Emergency and Essential Surgical Care being developed by WHO. In 2014, the International Federation of Medical Student Associations released the first policy statement by students and trainees on global surgery, which called for action and attention to global surgery and led to development of what is International Student Surgical Network, the largest global surgery body in the world, which we'll hear more about tomorrow. In December of that year, we had the G4 Alliance for Surgery, Obstetric, Trauma, and Anesthesia form. In March of 2015, the third disease control priorities was released, and there was an entire chapter dedicated to surgical care as a whole volume. In April 2015, we have the Lancet Global Surgery Commission's famous report that we have seen referenced multiple times today as well. And in May of that year, we see the first ever resolution by the World Health Organization on access to surgical care. Parallel to that resolution passing, InciSioN announces May 25th as Global Surgery Day that year. In 2017, we see the Association of Academic Global Surgery form, and in 2019, we have the second resolution by the World Health Organization. May of 2020, we saw the Global Surgery Foundation being initiated, and in December of that year, the National Surgical Obstetric Anesthesia Plan Manual was released by the Foundation and Harvard Program in Global Surgery and Social Change. Coming down to May of last year, where the World Health Assembly actually passed 3 resolutions that had ties to surgical care, and we also saw the launch of Global Surgical Fund. Now, the World Health Organization is at the core of the global efforts when it comes down to surgical care, and they have a program for surgical anesthesia care. This program is nothing new. It actually has been part of the World Health Organization's constitution since 1948. Again, begging the question that if WHO is so aware of issues and disparities in access to surgical care, what are they doing and how are they helping us overcome them? So I'm just going to go through a few of the resolutions and touch on them. Most important one would be the 68.15, which was on strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage, which was passed in 2015. The World Health Assembly resolution is essentially an agreement, a contract between the countries who are members of the World Health Organization and the World Health Organization, which is a technical body. A body of the resolution, if you look at it, has an introduction portion that talks about whatever that health issue is, in this case, of course, surgical care, and then it's followed by usually responsibilities and deliverables of the World Health Organization and then by the member states. 68.15 has many items in it. A couple of things that are very important to highlight is that the member states, countries, committed to reporting data on their status of access to surgical care. Because if you go back and look at the Lancet Commission's report, you notice that a lot of the data was missing. And there is a lot of modeling that went into projections that they had to make because it was never reported. For example, if you focus on the Caribbean, a lot of that data was not available in 2015. The countries promised to continuously report every year on the status of their surgical care and their efforts. Versus WHO promised to create a global action plan for improving access to surgical care and also to create a position at Geneva office and at every WHO regional office, of which there are 6, dedicated to surgical care. Now, since 2015, the countries have somewhat reported, not everyone has kept up with the reports, and WHO unfortunately has not been able to keep up with their end of the responsibilities. There are multiple reasons behind that. First and foremost, WHO resolutions are not legally binding, they are just agreements. So there is no punishment for not, or penalty for not keeping up with it. And the other side is that there was the pandemic, and last but not least, every resolution comes together with a funding package, and if the funding is not available for any reason, what is agreed upon may not come to fruition. We have the next resolution, which was focusing at universal health coverage, and then the last 3 that were passed in the 2023. Now, when I say passed, I want to highlight that resolutions at the World Health Organization are passed by consensus. There is no vote. They just agree together, and if any one country raises an issue with the resolution, then they all have to come and negotiate for sometimes days to come into an agreement and conditions under which they will all allow for these resolutions to pass. So last year we saw the ECHO resolution, the Integrated Emergency Critical and Operative Care for Universal Health Coverage, which was building on 68.15. We also saw a resolution that actually was coming up very quickly over a very short period of time, and it was supported by the World Federation of Neurosurgical Societies and the G4 Alliance, and that had to do with folate fortification for prevention of spina bifida. And last but not least, one that was focusing on increasing access to medical oxygen by the World Federation of Societies of Anesthesia. On a national scale, we have national plans, the National Surgical Obstetric and Anesthesia Plans, which have 6 components that you can see listed. There is a manual for these plans that is available on the Global Surgery Foundation website that you can download for free and view it. Many countries have initiated development of their plans, and some are actually in the implementation of these plans. The latest to come up is Somaliland, actually. Focusing more nationally in the U.S., as you are aware, the American College of Surgeons has a large advocacy body, and they every year have a summit and a day at the Capitol Hill where they advocate for a variety of issues. I have highlighted 3 that are particularly pertinent to global surgery. One is funding for USAID to be directed to neglected surgical diseases. These are a list of different diseases that run a list from trauma surgery actually. For fiscal year 2024, the ask was $100 million to be allocated. Unfortunately, that was not approved and not funded. 2 weeks ago, we were in DC, and the ask this year was for $10 million for the fiscal year 2025, which we hope to see some funding on that. There has been an item for funding for research to determine the general surgery density that is required per 100,000 people in the US, and also one for a new legislation for visa that is specifically for academic exchanges in surgical specialties. Now, focusing more locally, I'd like to share some of the work that I'm doing in Texas as part of my fellowship with the Baker Institute and Baylor College of Medicine. I have 2 areas of focus. One is trauma care in Houston, and the other one is actually the equitable academic exchanges in global surgery. And to look into policies and make some changes to the policies that are local, I had to review what is already in place to support these initiatives, and I had to do stakeholder analysis, meet with the stakeholders, hear their points of view, and I apologize, my voice is gone today. And I had to then do some research on defining terms and parameters. For trauma specifically, I used geomapping, and for I apologize, my voice is completely gone. Can I ask for some water? It's really Don't worry about it, don't worry about it. Thank you. So in terms of the medical licensing issues, I had to do a look into the funding that is available for global health issues, because so for the global health for global health exchanges for medical licensing issues, I had to look into what is the funding that is coming to the state of Texas for these global health initiatives, as whenever we have a discussion with policymakers, something that comes up is what is the benefit locally, and to answer that, I had to focus on the funding for these programs. The outcome of my research leads to drafting of policy briefs, 1-page policy information packets for staffers and legislature, and hopefully in terms of the medical licensing, we are seeking a change to the medical licensing for a 90-day exclusive license for exchanges through the next legislative cycle in Texas. So you may ask me why surgeons should be involved in policy in the first place. We are all very busy with our practices, and there is no time hardly to do the missions that we want to do. And we might even have hesitations to get involved in politics, and especially if we don't have any aspirations of running for office anyway. So I would tell you that the population that is here today at this conference is very special, as you're all critical thinkers and analytical thinkers. You're leaders in your field, and every day at your job, in your teams, you are advocates for your patients every day in the work that you do. You have a unique vantage point. You see the problems in your system. And finally, I will ask you, if not you, then who? Who is going to come help those neglected surgical patients? Who has that power and eye to raise the voice for that? And here I have a list of a few of my mentors, colleagues, and friends who are from around the world, different specialties, different generations, who have been very impactful. And I want to quote Professor Manuel Macasa, who is the surgeon behind the 68.15 resolution. And he always tells us at InciSioN that you should take a chair and bring it to the table where the policy is being discussed, because otherwise the discussions will happen without it. Why ICS? Well, Dr. Newman pointed out yesterday that ICS has a relationship as the global body with the WHO. WHO has 194 member states. Over 70 non-state actors are also in formal relations with the World Health Organization. It means that they are able to deliver expert commentary and statements during the discussion of resolutions. And out of these, only 7 are surgical organizations. ICS happens to be one of them. There are other ally organizations, but purely surgical, there's only 7 voices in the room. In terms of of our community engaging in policy, there are a couple of challenges. First and foremost is education. We are typically not trained in how to engage with policymakers, or how to write policy, or how to even interpret policy. Most of us may not even be aware of how everything works at WHO or at our local legislature. We have a communication barrier. Many of you are advocates for your patients, advocates for global surgery, but how many of you are comfortable to deliver a 2-minute elevator pitch right now to a minister of finance? And we're not capable of that communication without proper training. And also, when it comes down to the pandemic, if you look at some of the issues we have with misinformation and disinformation, we are not very well equipped to communicate with our patients in large quantities in a group setting with the population, and that's a problem because patients hold the votes that bring on policies. Finally, in terms of networking, unfortunately, we tend to work in silos, again, because we're all very busy. And as global surgery community, we also have siloed ourselves off a bit from the major global health organizations and interacting with other global health stakeholders. So as a very junior member of this organization, I have a few thoughts. ICS, as I highlighted, has a very special place in this arena, and perhaps creating a committee that is focused on advocacy and policy would be helpful. Developing educational opportunities for members within the organization so we can train, we can knowledge share with each other, and tap into those resources of our colleagues who are outside of the organization and are experts in this regard would also be helpful. Networking and engaging with organizations within global surgery communities imperative, also with other global health individuals, because again, going back to Professor Makasa's words, if we don't take the seat to the table, discussions will happen without us. In a few weeks, WHO will be discussing a pandemic report, a tool to prevent pandemics and prepare for future pandemics that are going to happen. And so far, every conversation for pandemic for the past 4 years has excluded surgical systems. And if you think about what you went through, what the surgical systems went through around the world, I guarantee every one of you agreed that you were not only involved, surgical systems saved everybody's life, and there is no preparedness without us. However, we're not part of that discussion, and we need to change that. Thank you so much again.
Thank you, Dr. Madani. Dr. Santana has joined us.
Good morning. Our next speaker is Domenech Asbun. He's going to be talking to us about safe cholecystectomy on a global scale.
Good morning, everybody. Good morning. I'm Domenech Asbun. I am a liver and hepatopancreatobiliary surgeon based out of Miami. Thank you very much, Dr. Madani and Dr. Corbin, for your fantastic presentations. I'm going to be talking about something a lot more specific, but I want us to keep in mind what we've heard over the last two conversations, primarily being the impact of health inequities on outcomes, as well as the effect that concerted efforts can have on the changes that we can have. I'm sorry, I'm not sure what this is pronouncing on its own. These are my disclosures. So I'm going to be talking about cholecystectomies and one specific area of concern as it relates to the way we do these in general surgery and other specialties. So cholecystectomies, first of all, for background, one of the most commonly performed, and in many countries, the most commonly performed abdominal surgery. Based on some of the data that we have, in the US, we perform at least 750,000 cholecystectomies a year, Brazil, 80,000, India, 200,000. And so needless to say, this is an important procedure. Now, laparoscopic cholecystectomies first were performed in 1985 by Dr. Mue. He was a German surgeon and avid cyclist. who initially was discredited and essentially attacked for his approach to cholecystectomy, but eventually was redeemed. And even though this really propelled what became the revolution of laparoscopic surgery, this was coupled with an increase in common bile duct injuries. And bile duct injuries are not the only outcomes to track when it comes to cholecystectomies, but is arguably the most important. Why is that? Bile duct injuries, as a complication, can have a very important impact on outcomes for the patient. So risk of bile duct injury during laparoscopic cholecystectomy now is considered to be about 0.3, 0.4%. There was a actually very recent publication that showed that in over 1 million Medicare patients in the U.S., the risk for laparoscopic cholecystectomy of bile duct injury was 0.1%. This is a potentially devastating injury. It can have both short and long-term effects. Some of the studies show that up to 70% of patients will suffer long-term morbidity with a decrease in quality of life. Up to 20% of patients can suffer long-term mortality related to complications from bile duct injury. Now, that's a very high number, but it is shown in a few different reviews. And of course, it can have both an economic burden for healthcare systems as well as medical legal implications that are very important. Now, this is only what we know. And we're going to come back to this point, again, ties into what we heard, especially from Dr. Corbin. These impacts are potentially much higher in low and middle income countries. Now, in response to this, the Society of American Gastrointestinal and Endoscopic Surgeons, SAGES, which most of you are probably familiar with, it's a society that much of its purpose is centered around minimally invasive surgery. And so they, in 2014, during the presidency of Dr. Brunt, there was a call to action, essentially, to try to attack this problem with bile duct injuries during cholecystectomy, during laparoscopic cholecystectomies. And he founded what was called the Safe Cholecystectomy Program. It became a task force and then a committee. And the essential mission was to adopt a universal culture of safety for cholecystectomies to minimize the risk of bile duct injury. Now, we don't have to read all of this, but these are the 6 tenets of it. The material, the teachings of the Safe Cholecystectomy Program are much more nuanced than this. I'll give you guys sort of a preview as we go along, but essentially they focus both on technical aspects of cholecystectomy as well as cognitive aspects, and what can surgeons do, again, to have a culture of safety, to have an approach to cholecystectomies that can affect the patient in multiple different ways. So when the Safe Cholecystectomy Program is implemented, it can decrease risk of bile duct injury. It can improve intraoperative cholangiogram interpretation, which is one of the things that's reviewed in detail during the program. It can improve surgical judgment, again, speaking to the cognitive aspect of this, and it can decrease conversions to open. There's also a lot of emphasis on what are called bailout maneuvers. So if you can't perform a full cholecystectomy in a safe manner, what are your options? What's your plan B, your plan C, etc.? And understanding the teachings of the program increases the use of bailout maneuvers, which is a good thing. Now, the implementation of the Safe Cholecystectomy Program has led to multiple guidelines, multinational guidelines that advocate for use of the tenets of the Safe Cholecystectomy. And these are 2 of the most important ones, the Tokyo Guidelines and the Multi-Society Practice Guidelines. And it's taught in the U.S. and in many countries around the world as the important way to look at cholecystectomies. This is how you do it. And these are topics that are essentially discussed with interns, with early trainees, things that are, some of the terms used are used every day during cholecystectomies. But what's interesting is now, 10 years later, when we look back at how we're doing, we realize we're not doing that well. Some of the studies that have looked at the use of the critical view of safety, and the critical view of safety is, without going into too much detail, it's essentially a way to prove that the structures, the anatomic structures you're dissecting during cholecystectomy, the cystic duct and cystic artery, are actually the cystic duct and cystic artery. When there is confusion about what structure is what, or when there's inflammation or other reasons that you can get confused, aberrant anatomy, etc., there can be a misidentification of the structures, which leads to bile duct injury. Only about 15 to 20% of surgeons tend to identify the critical view of safety during laparoscopic cholecystectomy. Online educational platforms tend to have very poor quality control. There was a study that showed that only about 70% of educational YouTube videos showed adequate technique. Now, I'm actually just yesterday reviewed a paper that did another review of online resources, YouTube, and on a Facebook group. And this is for robotic cholecystectomy, but essentially it's the same technique. Only 8% of videos had adequate technique for doing cholecystectomy. There's widespread misinformation. This is a clip from MedTube, which is another common online platform. What you see here is the clips already on one anatomic structure, and this is being considered the critical view of safety. This video is titled the critical view of safety. It's a very often watched video, and this is not the critical view of safety. And again, just goes to show how much misinformation there is. And this has been shown to be not just because of the cognitive misunderstanding, but also because of the technical details. People aren't using the right techniques. Now, what is the impact in low and middle income countries? And again, as Dr. Newman pointed out, we say low and middle income countries, but the reality is we're talking about low resource settings, right? Because even in the US, the impact of complications is much higher. Now, under the idea of a low and middle income country having a higher impact, we have to first realize that 90% of the world's population live in LMICs. There's an increase in use of laparoscopy in LMICs, and even though the data is lacking, it seems that there's very poor identification of critical view of safety and other safe pulley tendons. So one study out of China showed that only 9 to 18% achieved the critical view of safety. Less than 25% of surgeons in Brazil saying they knew what the critical view of safety was were actually demonstrating it. And it seems that there is a significantly increased rate of biliary complications during laparoscopic cholecystectomy. Again, unfortunately, the information is sparse, but from published studies, 3% in South Africa, 4% Nigeria, 5% in Ethiopia, 2% in Montenegro. And I'll remind you that what is now accepted as normal is 0.3 to 0.4%, and so these are significantly higher rates. There are high rates of surgeons reporting bile duct injury, so 35 to 40% in one review of Brazilian surgeons mentioned having bile duct injury, and up to 86% of surgeons in India mentioned having bile duct injury, with 78% of them saying had more than one bile duct injury. Again, these numbers are concerning because this is such a common operation. And so what we see, as Dr. Corbin was mentioning, is that with the decrease in resources, you have higher impact of complications, higher mortality, higher long-term morbidity, higher economic consequences, lower quality of life. A lot of this is common sense, but it is backed by the information that we have, because a lot of it is missing. So what can we do to improve the current situation? And honestly, this would go for high-income countries as well, based on the information we know, but my interest in this topic is impacting low-income countries. First of all, we need better data collection. We need to improve outcomes reporting. We need to have more standardized databases, just overall follow-up on outcomes. This is not something that's standard. We need to have better education, as I've showed you guys, even on educational platforms, even in people who are positing themselves as educators, there's widespread misinformation and misunderstanding. And this isn't, I don't say this to be accusatory, because it's very easy to learn something the wrong way, or to hear something your first year of surgical training and then throughout the years misremember it. The problem is we don't realize that we are misinforming surgical trainees and surgeons around the world that are starting to adopt laparoscopic cholecystectomies. And importantly, as Dr. Madani mentioned, we have to have increased global collaboration. This is not a problem that will get better on its own. So to this end, my project on this was sort of born through the Safe Cholecystectomy Committee in SAGES. I'm also a member of SAGES. And I created what's called the Global Safe Cholecystectomy course. Dr. Vityananthan was very important in conducting this. We've had one pilot program in Costa Rica at the end of last year. And essentially what I realized, this was actually during a trip a few years ago in Costa Rica, through another laparoscopic training course, I gave a 20-minute lecture on safe cholecystectomies to a lot of surgeons, and emphasized the critical view of safety, emphasized all these safe tenets of cholecystectomy. And 2 days later, we were in the operating room with these surgeons, and we were there to support the attending surgeons, the practicing surgeons, during their training of the junior trainee surgeons. And what I realized in 4 or 5 cholecystectomies that I saw, none of them used safe cholecystectomy approaches to a cholecystectomy. And again, I thought I gave a great lecture. Clearly, no one remembered what I said. And so what this told me is that, you know, we act like these are basic things. We act like it's basic information, but it's a lot. It takes a lot to learn the details, to implement them. And so what I wanted to do is really force somebody to learn this. I learned a bunch myself in putting this program together, but I created essentially a 3-day course, split up into about 4 hours each day, which was meant to be immersive and with a lot of repetition, using a lot of the basics of adult learning, so repetition, recall, short amounts of time. You know, we didn't have 45-minute lectures or 15, 20-minute lectures, a lot of group discussion, a review of data, etc. And the idea was to really have participants of the course feel like they were understanding the material, and emphasizing the fact that even though this seems like basic information, it's something that we should all take very seriously. So in that pilot course, it ended up taking about 5 months to put together. It was conducted all virtual, and you know, this was after a handful of discussions of whether it should be an in-person course or virtual. The course itself was created from day one with discussion of local surgeons, and by design, this course is meant to be reproduced in multiple different countries and cultures, but every time it should be shaped a little bit to the local culture. And so we discussed this with the surgeons. They said, look, there would be better access to the course if we can do it virtual, so we did. We overall had 24 surgeons attend a 3-day course, which is actually a pretty good turnout because it's a small country without a lot of surgeons. We had local surgeons not only help us create the course and customize it, but also give us a presentation at the end, or give the course participants a presentation, so that you know they could say, okay, if you have a violent injury in San Jose, Costa Rica, who can you call? We ended up seeing an improvement in the difference between pre-course and post-course knowledge. The participants had an exam, and we also asked them to send pictures during cholecystectomy, both before the course and after the course. And what you guys see here on the right, on the top, is when one of the surgeons was operating, and they placed clips before the course. This is not the equivalent of safety. This is not considered a safe way of, even though for a general surgeon, clearly that's a cystic duct. But again, it's not the safest way. It doesn't take more than 1 or 2 violent injuries in your career for you to be very scared of cutting the wrong thing. And then the bottom picture is post-course. This is a very nice review of safety. The surgeon did a great job of implementing what we had discussed. So moving forward, there's been progress on this topic. Again, 10 years ago, there was a concerted effort by one of the biggest surgical societies in the U.S., but we still have a very long way to go. I think collaboration is very important. Again, this is especially as we move outside the U.S., it's important for us to involve all of our colleagues, and even more so in countries that are just starting to adopt laparoscopic surgery, and the impact, of course, can be exponential. Please, if anybody's interested in collaborating and discussing this project in the future, I would love to have a conversation. You guys can find me here, whether it be my cell phone, this is my email, et cetera, but yeah, I'd be very happy to continue this in any setting that someone's interested. Thank you guys.
Thank you very much. We'll keep the questions to the end. Moving on, next speaker is Dr. Ricky Warren. He's going to be talking to us about the expected and be ready to adapt a thoracic surgeon perspective on international voluntary medical services.
Thank you very much, Simon. It's a great pleasure to be here, participating in this forum. Thank you very much for Professor Vidyanathan who invited me, and he asked me whether I could just give a talk experienced global surgeon, and said I'll try and do it. And basically it's going to be a show and tell, nothing scientific. And one of the questions, and there was some discussion earlier yesterday, what is the society benefits? And the most important thing, I think, is meeting people, networking, just globally, making friends who are with you forever. And I had the privilege of being the president of the society about 15 years ago, and I still cherish my activities with this organization. So most of us here want to do global surgery, and it's just taking the first step. It's always hard, and there are some myths. We think that you have to follow, and not necessarily you have to. I hope my talk will sort of shed some light how you can do your own missions. And if you have an open mind and desire to serve, and it helps. And it doesn't have to be practice you're having now that you don't have to take. You can do a lot of ways of doing global surgery or global medicine, global volunteerism. So that's what we have to think. My exposure started a long time ago when I was training as a, we call it carrier registrar. I was in Scotland in cardiothoracic surgery. That's 1984, when one of my surgeons asked me whether I would go across the ocean to Iraq to work in a hospital in Baghdad doing cardiac surgery. It is, so he wanted to go with him as a first assistant. And I took that opportunity and jumped on it right away. It was something, different, new, totally unknown. So I wanted to go. And we went there. It's called Ibn al-Bida Hospital. They wanted to start a cardiac program there. University of Baghdad had a cardiac surgical program, but they were mainly doing valve surgery, closed valve surgeries mostly. Coronary bypass surgery was new. They haven't been doing coronary bypass surgery. They don't want to try that unless somebody else can come and teach them. And the other thing was also pediatric surgery. Pediatric cardiac surgery was not, they're not very comfortable with, except they were doing some ASDs and PDAs. So that's how I got involved. We took a team, surgeons, first assist, anesthesia, perfusionist, ICU nurse, and that was a team. And this was a sponsored visit by the government at that time in Baghdad. And it was a specialty hospital. They had never done cardiac surgery, but there was a resident cardiologist who was an expat. So they were working up the patients, and we knew exactly what we were going to do there. We had total support. Infrastructure was there, but for us to practice. And that, it was a 2-week mission. 1 week we operate, 2nd week take care of the patients, and then leave. And I did that twice with a 6-month period with 2 different surgeons. And it was very, very eye-opening. And then what happened was, I did not know that this was going to be, that's the unexpected part. I ended up taking a job there as a resident surgeon with another surgeon who came from Sweden, Dr. Thomas Lubial. So we were 2 surgeons, and we established a program doing surgeries every day. I was there for 6 months, and then returned to Scotland. because I thought if I stayed in Baghdad, it's much kind of cushier life, and I might get used to it. And then I want to get back to my training and want to finish. That was my first exposure. It was a very organized program, so it was made very easy for us to go and do what we want to do. So I just continued my training in Scotland, then I moved to London. I was in the St. Mary's Hospital, Paddington, Imperial College Medical School. And we used to have a connection with the National Health Service with Gibraltar. And so we used to have patients come over from Gibraltar, flown in for surgical treatment. And then I was asked that I would go to Gibraltar to do some surgery. I said, instead of them applying in the patient, they want to fly out the surgeon. So I said, okay, I'm happy to do it. So I went to Gibraltar for 10 days, seeing patients, but at least I had some idea what kind of patients I'm going to be seeing. But it's again, you just go to an unknown place, just have some idea, but be able to be prepared and adapt. And that's very, very important as going as a voluntary surgeon, because you don't know. It may not be the same as you're used to, but you should be able to adapt. So, in review cases, the consultation, the surgery, took care of the patients, and go back. So that's my second field. This time I went by myself, so I didn't have another surgeon go with me, a senior surgeon. So that's kind of different form, but at least I knew the National Health Service. So it was going to be some support, but at least it's, again, an unknown field. My third exposure was in Tashkent, Uzbekistan. As a matter of fact, a surgeon visited us in London, watching what we do, and then he said he had some cases he doesn't want to tackle, but I would be able to visit him and teach him how to do the cases. So I took that opportunity. Again, it's kind of, I like going to different parts of the world, seeing the healthcare, seeing what we can do, and just teach your skills to someone who can continue doing it. That was kind of, I was in England, then I moved to the United States. I had to settle down, do things, so it kind of took a while. But again, it was still in my mind what I want to do. But then I have been invited by colleagues to go work internationally, but it's almost well-set organizations, universities. You go and do some cases with them. They kind of feel comfortable continuing to do the cases. I've been to Bangkok, Thailand, back to London, doing some cases there. So that was kind of kept me going on these international missions. And in 2005, of course, probably a lot of people remember 2005, 2004, December, 25th, 26th of December, the tsunami. So it wiped out a lot of parts of Sri Lanka. So in January 2005, I went to Sri Lanka on a medical mission under the auspices of International College of Surgeons. We took medical supplies. I went with another surgeon, a colleague, and anesthesiologist, and a nurse. That's our team. And I think we took some medical supplies. Essentially, it was very different. It was not surgical mission, basically it was a medical mission. And we met up with a team who came from England. One of them was one of my old batchmates. And we went and did medical clinics in small villages. I was prescribing medicines for blood pressure, diabetes, because all kind of, they lost their medicines with the tsunami. And so that was different. It was, we traveled from different parts of the country along the west coast, my home country, hometown in Jaffna, and it was something very different. But it was no surgeries. Now that surgery was done, all medical treatment. But that is also needed. That's what they needed at that point in that country. And so you need to be able to serve the local needs. Don't go with preconceived ideas what you're going to do, because otherwise you'll be frustrated and not be able to get you to the idea of doing surgical missions. Then we went to another part of the country, again in Sri Lanka, and shortly thereafter, and this time with the surgery. Basically, there were places I was going where medical help was not readily available, or there was the civil disturbances. People could not go to certain parts of the country to do it. And this time also, I went with the anesthesiologist and another surgeon, and they asked us whether we could do some surgeries. Interesting thing is, the surgeries I was asked to do was something I'm not doing it on a regular basis. And the local medical officer asked me, can I take this kidney tumor out? I said, well, I haven't done kidney surgery for quite some time. He said, well, if you don't do it, the patient will not have surgery. I said, I've done it, kidney surgery, but it's a long time ago during my training, general surgery training. I haven't. He said, okay, well, please do this case, because we're not going to be able to send this patient out, and she's going to die. So I said, okay, we'll review the patient, talk to the family, told them that, I haven't done this surgery for a long time, but they said, it's okay. If we can help in any way, we'll be grateful. Doesn't matter what the outcome is. So we said, okay, let's go to the surgery. So the day of the surgery, next morning, the patient was there. So I said, we need some blood. They said, yeah, we have a couple of people waiting outside. I said, what do you mean? Well, we don't have a blood bank. So these are the family members. They're willing to give you, donate blood. I said, okay. So they said that. She said, that's what we do when some people need blood. We give just for the family members. I said, okay. So we went to the operating room. Patient was there. So my anesthesia friend, who was my colleague, working regularly with us, and I used to do some big cases with him, so I was very comfortable. He can handle anything, do transplants and things like that. So he came and told me, DeBakey, we don't have a ventilator. I said, what? He said, no, we don't have a ventilator. We don't have a blood pressure monitoring, but we have a pulse. I brought a pulse oximeter. And he said, I found somebody who can squeeze the bag. I said, are you comfortable doing that? He said, yeah, I'm comfortable. Are you comfortable? I said, sure. Because the patient says that she will die and you do something, and as long as you can maintain the oxygenation and ventilation, I'll take care of the surgical part. So yeah, okay. And so actually we did that case. This person who he recruited is somebody who is not medically trained, but he's because of the war, the Civil War, he's one of those people who are actually helping in the jungles to people with injuries. So he had practical experience of how to do things, but not medically trained. So he said he will be able to squeeze the bag throughout the operation. So he was sitting there mentoring. I had a pulse oximeter and an EKG monitor, and that's all. We did the surgery. So that's totally unexpected. Patient did well. We took a big mass out and no blood loss. And she did very well and recovered. Of course, there was other cases lined up for me also. There was a parotid tumor, which I haven't done it for a long time. Some lipomas in the chest wall, that I would have been happier to do. I'm used to that. And there was some inguinal hernias, which again, it's been a long time, I didn't know hernias. And we did all those cases. And the thing is the team. I think I had a person who is gutsy, and also I trusted him totally that he can do it. Otherwise, I wouldn't have embarked on any of those things because it's dangerous. So, but we did those work, and I must say, the training I received during my training really helped. I mean, I was broadly trained, and this, I thought that I can't trade that for anything, because that's something you learn, you keep it with you. Then, during our visit, we saw what things were happening, and there is another thing you can do. You don't have to always do surgery. If you have the will to do something, you can always help the community. As you heard earlier on, local economy is very important for health. So what happened with tsunami is a lot of the people who were fishermen lost their boats. It's all gone. So the community has no income. They can't go back into the sea because they didn't have. So I partnered with the local organization. As a matter of fact, this guy is your current president's brother. And he was actually organizing he's an engineer from MIT. He was organizing a local fundraising and grants to provide boats for the fishermen. And he mentioned this, I presented it to the American College of Chest Physicians. I was in one of the leadership of positions there, and at the government, I think, at the time. And I received a grant to actually support that village, to provide boats for them. So I just also, it's one of the biggest grants they gave for a single person to do voluntary work. And so we really, you can see, provided some boats for those people. And they rebuilt their community because of that. Again, the point is that you don't have to go and do surgery what you do every day. If you want to help the community, you can go anywhere in the world and you can help them. And it really give them the opportunity to maintain their health. So it's really in some other way helping them to build their own community and have a healthy life. Then I had the opportunity to go with the American College of Chest Physicians on an ambassador program. This, again, this is not, so there were surgeons and physicians, but we were going as a friendship organization, the local chapters of medical chapters there to educate about critical care, talk about critical care, maintaining, managing chest diseases, essentially. And we went to Vietnam, Ho Chi Minh City, and also Cambodia. And we spent about 2 weeks traveling as a group and met many medical students, residents. We had small roundtable conferences talking about different issues they have. And that was another very, very exciting way of really exchanging knowledge and friendship. And you can see, and also you have also an opportunity to see how they practice, what they have, very little they have, and they can still do a lot of work. And we have this idea of working in very, very good places, and we feel that if we don't have everything, we can't do anything. But it's not true. We could actually provide help and advise, assist in many ways. The next opportunity was, I had the opportunity to go represent an International College of Surgeons, and in joint partnership with World Surgical Foundation. I guess you can see young Alvia there with me, World Surgical Foundation founder and the president. We went to Ethiopia for 2 weeks. We took over, we was invited by the university hospital, we took over 5 out of the 6 operating rooms and operated for 2 weeks. And there was a thoracic surgeon, myself, went from ICS, orthopedic surgeon, OBGYN physician from the ICS, and then Dr. Alvia brought colorectal surgeons, pediatric surgeons, general surgeons. So we were operating for 2 weeks in Addis Ababa hospital. The local surgeons kept the one room for the emergencies. But the most important thing is we were working with the local surgeons and letting them do the cases, training them to do the cases. So that was kind of different way again, something else. You can actually assist the local team to be confident with what they do. And here again, I took my same anesthesiologist because we knew that we could do some interesting things. So the goal was provide service, teach the local team, and also help them with the building teams. And also while I was there, we started a new chapter in Ethiopia for International College of Surgeons. The interesting part of here is, again, you have some expectations, but it can change. In this case, I had an esophagectomy scheduled. Three esophagus cancers, and then we did several thoracic cases. Me for doing thoracic cases, but then there were a lot of other people doing other surgeries all the time. But like what happened in Sri Lanka, my anesthesiologist came and said that his EKG is not working. He doesn't have EKG, but again, he had a pulse oximetry. He travels with the pulse oximetry, and he said, we can't monitor the blood pressure because the blood pressure cuff, I can't keep squeezing it all the time. It's a manual one. Again, he said he's comfortable doing the cases. So we did the case with the pulse oximetry and occasional checking the blood pressure. And I took the surgeon who was a junior faculty member to do the case with me. We did an Ivor Lewis. Everything went fine. But the next day we found out the problem was the EKG leads had so much glue on it, and it was not really conducting electricity. And he figured it out, and he scraped it up. In the next case, we were having EKG monitoring, and also we had an automated blood pressure monitor. This was provided by the local, one of the surgeons. Apparently they had it, but they were hoping that we would bring something and give it to them. We didn't realize that, but then they gave us the blood pressure med, the EKGs. We did the rest of the cases with monitoring, more monitoring. And as you can see, I had to put the x-rays on the window because there was no x-ray box to see the light from outside. The operating room was basic, but still we were able to conduct surgery because the university hospital, the ICU was good. And my surgeon who assisted me told me that all the surgeons did very well. I only had a telephone conversation because I left after the surgery. He said all patients did fine. I hope, but I don't know whether he was trying to please me or not. But at least his version is no problem with any of those cases. We did. Then in 2010, I had even another unexpected opportunity, and it was a good experience. The University of Illinois Champaign, medical students there, undergraduate students, wanted to do a medical mission in Honduras. And so we went about 30 students, 3 physicians, 1 dentist. So we the people who went there to do the work. I'm the surgeon, and there was a family practitioner and an internal medicine doctor and the dentist. And we saw, I think we saw patients, close to 170 to 200 patients every day. And they were coming through, and I was basically treating wounds, broken bones, just cut, wound cuts, nothing major. that's diabetic ulcers, that kind of stuff. But still, they were comfortable having a surgeon around doing it. And the greatest thing for me was my daughter was with me. She's one of the organizers of the medical brigade. I mean, that's how I got involved. She said, "Can you come with us?" I said, "Sure." My youngest daughter, not the older one. Older one is second. So it was, again, unexpected. It was an unexpected thing, but it was a great experience. And again, we did something different. And in 2015, I went back to Sri Lanka, took a endoscopic tower with me and donated it. This was really in collaboration with the College of Surgeons of Sri Lanka. So it's interesting that they asked me in the main hospital in Colombo, they want to know how to do minimally invasive lung resection. So I was really taking the surgeons through muscle sparing thoracotomies and some thoracoscopic surgery. That's for 2 days in Colombo. Then in Kandy, which is another central part, they want to start a heart transplant program. And I'm a transplant surgeon, so they want to have discussions about the infrastructure. So we had a discussion. This was also not only College of Surgeons, but also the Health Ministry organized this. So they want this kind of discussion with them. So that was something different, totally doing surgery and talking to people about infrastructure, how to build infrastructure to do it. And as a matter of fact, 2 years later, they were doing the heart transplants. They have a heart transplant program there. Then we went to the north, where we did some surgeries, and one of them was a retrosternal goiter. They had it lined up for me to do it. But that was a surprise, unexpected. Because they were thinking of starting a cardiac program, so I expected them to have maybe a sternal saw. But so when I went to the operating room, I said I need the saw. They handed me an orthopedic saw. So it was kind of open-ended, just a small blade, and they said, "This is the saw we have." So it was kind of, now I had to open the sternum, and they said, "Do you have a chisel?" I said, "No, we don't have a chisel and a mallet, because that's the other way you can open a sternum." But so I have to put a malleable retractor behind, squeeze it behind the sternum, and use this orthopedic saw to open the upper part of the sternum to take the retrosternal goiter. And also, the other interesting thing is, I asked for a retractor, they gave me a Wheatlander to open the sternum. So that was a self-retaining retractor, which doesn't hold power. So I have to squeeze in a couple of Wheatlanders and get two assistants to pull the sternum each side when I was taking this goiter. But fortunately, the retrosternal goiter, I was able to get it out first, then finish the operation, so it was done. But these are, you have some idea what you're going to get, but you may get surprised. It's totally unexpected. I thought, I was going to have a sternal saw. I mean, I didn't even think about it when I would do the case, because it's going to be there. No sternum, no retractor, no saw. So it is, I had the choice of canceling the case or proceeding with it. And so after kind of a little bit of deliberation, I said, okay, we will be able to get this done. And fortunately, we were able to do. Interestingly, I found out later on, they did have a sternal retractor and a sternal saw, but it was in somewhere in the storage, because they haven't started the program, but they got the instrument, but they haven't got them, and nobody could find where it was. But it's interesting. Oh, this is what I was given. So in summary, just to summarize that, first of all, you have to have the desire and the drive and commitment to serve. That's very important. Have an open mind when you go to an area where you have never been. You don't know what you're going to come across. But you should be able to adapt to the situation. if you plan ahead and if you have a good team, already know what you're going to do, you can be productive. As like what I did in my first experience going to back then, we had it all organized. Everything was organized. So it's just like I was doing surgery in Glasgow, in Scotland. Just same thing, different patient. That's all. Anatomy is the same. Inside everything's the same. But also know your limitations and know your team's limitations, what you can do. And don't take things for granted. The other thing is have a team. The thing I had when I went to Ethiopia, Dr. Alvia had a whole lot of people there. And I had we also took a endoscopic tower, and people he brought in with him was able to get that set up for esophageal cases, because otherwise I didn't have an endoscope to check the patient beforehand. But that's very nice, if you have a whole lot of people around and work with the local people. And it's also very, very important to respect the local culture. You don't want to be show off. Basically, you want to sort of work with them, and you're trying to really help them. And it's important to get them to do what they can do and help them what they want to do. And there are going to be a lot of unexpected things. That's inevitable when you go to a completely new environment and you're trying to do surgery. Especially if you're thinking about highly specialized surgical thing, because you take a lot of things for granted in your place. When you go there, you may not have it. But do adapt to the situation. And the other thing is also, I say, surgery may be not on your menu. You go there, maybe they want you to do something else. So, okay, that's all right. You have been trained medically. It's not like you can't do it, but you can actually help in some ways, not necessarily the way you used to do at your workplace. And you make a lot of new friends when you go there. That's another important and very enjoyable thing. And enjoy the local culture. I did not know until I went to Ethiopia, they have a coffee ceremony. They make the coffee in a very special way, like a tea ceremony. They make this coffee. So that was kind of very interesting. And we also ate food from a big tray with the hand, sharing the whole tray with everybody. So it's a different thing. It's kind of good to kind of know that and always fresh your memories. I like to kind of conclude saying, when you go for medical missions, have the right attitude when you go there. And don't forget your Hippocratic oath. Do no harm. If you think that you cannot do, don't try. It's very, very, very important. And they may not get the surgical procedure you wanted to do, you thought you were going to do, but at least you can do, help. And you're really making a difference to somebody. That's the most important thing. When you go to things, you are really making a difference. And that's where the joy comes.